l'anglais. Pour changer la préférence de langue, veuillez cliquer l'icône Interprétation
on
pour
interpreting to select either the French or the English.
Series. The webinar today will be presented to you in French with a live translation from French to English. To change your language setting, please click on the interpretation icon to select either English or French. Tomorrow, we will be sending a copy of the presentations in English, along with the link of the recording to our non-French speaking participants. Si vous rencontrez des problèmes techniques pendant le webinaire,
if you have technical problems, just try to reinitialize the page on your web browser or send us a message privately in the discussion box, the messaging question and answers. The presentation tonight, as well as the recordings of our series, Gutsy, are available on our website at the address on the page and on YouTube. The period of question and answers will be based on the questions that were asked beforehand during the registration and during the live diffusion. That being said, if you do have questions during the presentation, you can write them down in the messaging box that you see on your screen. We cannot respond to questions on particular medical situations or personal ones. I am called Ariane Laboissonnière. I will be your moderator tonight. Thank you once again to our webinar. I work for Crohn and Colitis Canada as a coordinator in the development for the regions of Quebec. My role consists in organizing events, funds, fundraisers, and to collaborate on our diverse initiatives. The team from Quebec and the national team have collaborated together to show this series of Gutsy series, having a speaker, the exceptional speaker in Crohn Colitis Canada. Before presenting our conference speaker tonight, I would like us to start by sharing our promise. Crohn and Colitis Canada believes in curing Crohn's and colitis and to improve the lives of the children and adults with these chronic diseases. We work really hard to give information and resources that are up to date to support our communities during their journey with IBD. I would also like to take the time to announce the next events and our events of fundraisers. So our next webinar, COVID-19, will happen in November. That will be presented by the members of the group of work at COVID-19 of Crohn Colitis Canada. We would like to invite you to join us for the last updates and the best counsel for the people that are touched by IBD. The event will happen in English with an interpretation simultaneously towards French. You can register by scanning the QR code on the screen. It's the first QR code that you see on the top. In the red box, as well as stay connected for the updates on our website. There will also be learning for young people from 14 to 19 years old who live with IBD. The second event or symposium of Jacqueline Fisher that will take place every Sunday from the 14th of November to the 5th of December 2021 from 12 o'clock Eastern time zone. It's an event destined for young people and in the honor of Jacqueline Fisher, a young woman who unfortunately just died of the complications of IBD. If you are interested in participating, you can scan the second QR code on the pink QR code, so the second one on the bottom of your screen, to register or to stay and be informed on the website. And our volunteers and without these funds, we will not be able to do our work. And this year, Quebec and Ontario are associated to have a gala, virtual gala, from the 30th of November to 7:30 Eastern time. And they also have a silent draw from the 15th to the 30th of November that will happen virtually. There will also be a contest, an auction, a raffle in December for the province of Quebec. So stay tuned for more information. Tonight, we have a special guest, the Dr. Prévost Jantchou, who will present the factors of risk, environmental risk, and the causes of Crohn's or colitis, as well as the role of vitamin D in the prevention and taking care of the IBD. And Dr. Jantchou has received his medical training at the University of Sainte-Justine of Toulouse with a specialization of pediatrics at the Besançon in France. He did his stage of Gastroenterology, Pediatric Gastroenterology in Paris, and at the Gastroenterologist Jean de Flandre à l'Île-de-France. Dr. Jantchou has obtained his master's in epidemiology clinically, the evaluation of the actions of health in 2002. His interest is for the understanding of the incidence of IBD and the factors of risk associated, brought him to pursue his training and working on a doctorate in epidemiology in 2007 to 2010, Unity CERN in France. And in January 2011, Dr. Jantchou was nominated adjoint doctor at the University of Montreal and doctor of the Gastroenterology of the Hospital Sainte-Justine in Montreal. In May 2018, he was nominated associate professor at IDM as a clinician. He has teaching and clinic and research or at the Sainte-Justine. The interests of research of the Dr. Jantchou understand the factors of risk, environmental risk of IBD, in particular, what's linked to life, like physical exercise therapy of IBD in pediatrics, the quality of life at children attained by IBD, and the transition of children going to adulthood with IBD. And the Dr. Jantchou has received a study, GEA, the Crohn and Colitis Canada in 2018 to supply him in his study for the study of vitamin D in children who have IBD. And so without waiting, we have the honor of presenting and passing the mic to Dr. Jantchou. Welcome, Dr. Jantchou. Thank you very much. It's a pleasure to be among you. Thank you to everyone, to those who have been able to free themselves up to be here tonight. I see in the chat that there is an innovations in French, and I believe it's really a pleasure to do it in French and to share also this beautiful language and to be able to answer questions in French or in English for those who would like to have a response in one or the other of the languages. And we'll be able to have 1 hour of discussion and to be able to make the points on this theme. So the IBD and the factors, environmental risks. And so the first thing to underline is the conflicts of interest. There are no conflicts of interest that underline. So that's important to always start by that. We will talk today about inflammation. We will talk about the factors of risk. But I wanted to underline to get to that point of epidemiology of inflammation. I will give a little word on why it's important to talk about these risks, and we'll see what protects and what increases the risk. And finally, I will talk about our study, VDPEC, that had financing for Crohn and Colitis Canada that we would like to thank once more. And so during the presentation, we will have a few abbreviations. I want to underline them here to simplify some of the slides that you will see. You'll see IBD, Inflammatory Bowel Disease, Crohn disease, CD, and ulcerative colitis. You see all these definitions are terms that are used to explain the associations between a factor and sickness. And so we have a risk that is superior to one. That means that the factor concerned is associated to an increase of developing a sickness. And if it's lower than one, that means that the factor concerned is associated to a risk of protecting effect. So the studies that we'll talk about today are three types that we see. Studies that are retrospectives, and we look in the back. We ask the questions to the patient on their food consumption, and then there are the cohorts that are perspective on a longitudinal. And the third group that we'll talk about, meta-analysis. There are studies that are like a synthesis of everything that exists in literature and permits to define a kind of average on the risk. And then we'll talk about the relative risk when we talk about the family risks. And the first degree are brothers, sisters, ascending or descending. And then the second and third degree, we're getting farther away as we go down from the proximity. And so to see here the different risks, but it's important for me to redefine this before we start. And so, epidemiology of inflammation disease, IBD, published it in 2018. Data that showed that in Canada, in the province, the incidence is not the same. Provinces where it's higher than others. And we know that in 2018, there was 270,000 people that lived with IBD. And among them, 7,000 were less than 18, different forms of IBD, pediatric, and the projections for 2030 show that we'll have 400,000 Canadians that will have IBD, which represents about 1 Canadian on 100. And in the world, many millions that live with this IBD. And even though the rate of incidence seems to be stabilizing in adults, in children, we still have a progression of the incidence, especially for young children. That we put together since 2009, a collective data of patients to identify the number of new cases every year. And we realized that throughout the years, this incidence increases. And so between 2009 2014, we've had between 90 to 100 cases every year. And on the last years, from 2015 to now, we have about 120, 130 cases. So we have a sickness that is pretty important with the children and more than the adults, but incidence seems to be in progression in children right now. And so why is it important to be interested in this factor of risk that are environmental? And we know right now, the contrary to COVID-19, that is linked to infectious disease, SARS-CoV-2, for inflammation, IBD. There's not one factor by itself. We're multifactorial complex factors, that genetics, other epithelial, microbial, environmental, and immune. The first is epithelial of the intestine, and the second element is the microbiome, and the third element is the immune system. And so, because we're going to talk today about the environment, it's important to see what are the mechanisms why these factors can play. If we already start by genetics, the genetics is a factor that's very important. There was a lot of analysis that has been in studies that have been done. Over 240 genes identified and involved in different stages of IBD. But this does not explain 8 to 13% of the disease variants of CD and 4 to 7% of UC, which means that there's other things than genetics that explain why there are so many cases of inflammatory disease, especially in countries like Canada, which is one of the places in the world where the incidence is very high. And so the genes do not explain everything. There are other things, other factors, and the other factors could act through many different elements. The first element is the intestinal epithelium consists of a single layer of epithelial cells joined by tight junctions of interspersed with immune cells that permits the food to be absorbed, and there's a barrier between between the blood. And this epithelium plays a role with what's present in the intestine, and we'll talk about that as well. And so all the cells that constitute this epithelium are attached one to another by what we call junctions that are joint tight junctions. And when we're not together, we'll have what we call the permeability. It's a bit like an opening where where it's not very solid, and we have an infiltration of water that is done, and that permeability will bring bacteria and other antigens in this vascular system and start that process immunology. So it has a really important role in inflammatory disease. And on this picture here, we see how this epithelium is defined with the cells that is present in the epithelium with the internal face in contact with the bacteria, and the outside in contact with the digestion and the immune system. And so this epithelium plays an important role. And then after that, there's a microbiome. The microbiome is an organism that is alive. It's constituted of many bacteria, more than 10 to the power of 13 that are in the digestion tube, and represent 1 to 2 kilograms, and that's a lot. So that is dispersed from top to bottom, with the number of time is more important that will get closer to the colon. So it's important at that moment to define the role of this microbiome, and to see that the microbiome will also change according to different parameters. One of those parameters that is important to underline is the mode of delivery. By cesarean or by vaginal birth does not give the same type of microbiomes for the baby. Prematurity, if we're born before term, it will bring a certain microbiome. But intensive care stay, supply mode, breastfeeding, infant formula, that will play on the microbiome. And then there's other factors like a geography, where we take the microbiome of children au Benin, it will be the same as the children in Japan, or the same as children in Canada or Quebec, and that depends of the geographic environment that also influence the influenced by food and other factors as physical activity and sleep, are factors that influence the microbiome. And finally, the medication, in particular antibiotics, will modulate the microbiome. And so the microbiome has an important role it will play on the production of certain components that are important for the colon. These bacteria, the microbiome, have an important role for the modulation of the immune system. That is why we attached in the last years to more understanding and to characterize those microbiome. And to understand it and to characterize it, we're going to look at, on one side, the quality. That is why we're talking about diversity. And that's why we're also going to look at the quantity, and we'll talk about the richness and the number of bacteria. And so when there is a balance, unbalanced microbiome, we'll talk about dysbiosis, and that dysbiosis is associated to the coming of the IBD. And so, in the end, genetically, we will have factors of environment that will play by the modulation of the microbiome or by the epithelium, and all that will bring the cascade, immunological cascade, that will be at the origin of the starting of the inflammational lesions. So, these factors of the environment, there are many. We will analyze them together. The first factor, that is the oldest one, is the one that concerns the family history. So the fact of having a twin who has IBD will increase the risk to the other twin. If it's a sickness of Crohn, the risk is 50%. And the second twin develops also the IBD. So it's a colitis, ulcerative colitis. It's about 12%. And so we have one or many parents. The risk is also increased. So the presence of a parent, first degree, will increase the risk of developing the sickness of Crohn, or the ulcerative colitis. And we have two of the first degree, the risk is even higher, to going up to 10% for the sickness of Crohn's disease. And that risk will decrease according to the proximity with the case. So of the third degree or second degree have a lesser risk, but always superior to the risk of the general population. So globally, if we think a cohort of patients with IBD, there's about 12% among them that have cases that are family cases of IBD. And so we're going to focus this time on the period around the birth, and so the first moments of life. And one of the factors that was studied for the periods of birth is the smoking during maternal smoking during pregnancy. If a pregnant woman smokes, the risk of developing IBD in the baby the child after birth is very high. And so 50% more risk in a woman who smokes than developing IBD. And so, especially for Crohn's, it's increased by CD or UC. And so, taking antibiotics during the pregnancy, we also have an association that's important for the developing of IBD in the child that will be born in his childhood, especially the antibiotics were taken third trimester, sorry. And then the infections. So the presence of an ear infection during the first years of life increases the risk of IBD and Crohn's in children. And so all of these injections will give a risk that is much higher in a pediatric form of inflammatory problems as compared to adults. But what was noted was that other factors like cesarean, the weight, being born premature before term, is the fact of having received the vaccines like the BCG or MMR, and we administer these in the first months of life, and are associated with the inflammatory disease. So this period is important. A recent study that was realized in Canada shows that in particular the infections coming in the first year of life will bring an increase of risk of developing IBD before the age of 20 of 60%, and then an increase of 300% developing an IBD before the age of 10. And so we clearly have an association between the infections and the risk of developing these IBDs. And we'll see a bit farther that the antibiotics can be a factor that modulates this risk and this association. A second factor that we could study always in the first periods of life is the breastfeeding is associated with a low risk of being protecting for the development of IBD, but also for the development of CD or CU. And this protection depends also of the origins is greater in the Asians than the Caucasians, for example. So the milk, breastfeeding milk, on the risk of Crohn's as constantly found in many studies that it's pretty good because it decreases by 20 to 30%. And so in the first year of life, it seems to be a capital interest to show the situation on one side with the factors that will protect and other factors that will increase the risk. After the first period of life, there are other events of life that will happen, such as past 5 years in general, other factors that we will talk about, or the appendectomy is we're removing the appendicitis, that little end of skin at the end of the intestine, at the side of the colon, and this part of tissue has an immunological function. When we remove the appendicitis in children, is because of an appendicitis. And so the appendicitis is the first cause of what we call appendicectomy. And so there is an increase of the risk to develop Crohn's disease when we remove the appendix. And on the reverse, it has protects. So in these studies, one of the things that's observed is that this risk that is associated with the sickness that comes in the first 2 years, it is possible, especially with the association with the sickness of Crohn's, that it be already a disease that is present in this association that is a bit masked by the disease that is there. And we have tried to show this in a study here in Quebec, a big study that was done from patients born between 70 and 74, population that were followed up to 2014, and we were able to identify in the study in 2,000 cases and 1,034 UCs cases. And Crohn's is present when the appendicectomy, it happens between the ages of 20 and present after the. And so for what is colitis, the protection is present throughout. And so the appendectomy could be associated to the development of IBD by dysbiosis, the unbalancing of factors, bacterial microbiomes that we've spoken about already, or by permeability intestinal that will let certain antigens pass through and stimulate the immune system. Other factors associated in the first years of life. So the tonsillitis is to remove the tonsils. It's done in children that or have repeated problems, and it's a surgery that seems to be pretty frequent, especially in the later years, as the tonsillitis is being done less and less. But in the 10 to 20 years past, that it was done frequently for children as soon as there was an infection, repeated infection. So Crohn's is associated, tonsillitis is associated with the Crohn's disease. And for the ulcerative colitis, was demonstrated in many studies as well. They regrouped in meta-analysis. They were 17 studies for Crohn's and 22 for UC. And so the fact of removing the tonsils could bring the appearance of Crohn's. Other factors, the antibiotics, once again, it's a factor that is found a lot in children. Many will receive antibiotics for different infections, and many studies have showed to try to evaluate the situation between taking the antibiotics and the Crohn's and colitis. And what is demonstrated is the risk is more present for Crohn's of 74%, and for colitis that there's no situation. So this association is present when the Crohn's disease will be there in the children. So an important element to take into consideration. The contraceptives, oral contraceptives, another factor that have been studied, and in many studies were 4 and less. And all these studies have been reunited in meta-analysis, and we have actually data that shows the fact of taking contraceptives, oral contraceptives, increased risk, the risk of Crohn's and of CD and you see it, especially if it's on a prolonged period. And one of the factors that is really strong associated with an increase of the risk of Crohn's is the fact of smoking. So smoking is associated with the risk that's important for the Crohn's disease, but in a surprising way, a bit like we've seen for appendectomitis, it's decreased by half. So it's important as an element here, and it's not a factor for which we will encourage people to smoke, because the negative effects on other health issues are pretty important as well. But the role of smoking and influence of genetics factors and ethnicity is demonstrated in many studies. So there are certain populations for which the association is much stronger. And what is shown as well is that even for patients that have Crohn's, the effect of smoking increases the risk of developing those crises. So other factors that are important, that physical activity. Physical activity is a factor that is important to develop IBD, especially for Crohn's disease. For those who are very active, have a lower risk of about 40% developing Crohn's compared to those who are inactive or sedentary. This risk is especially connected to Crohn's and not with UC, but the activity will be interacted with the food intake and with the microbiome in the intestine. And so the physical activity has a role with the microbiome, has been shown in the animal models, but also in humans, but also the link with certain proteins, especially cytokines, that are inflammation proteins that are produced by physical activity that go play like a blocker of protein and of inflammation. And so the fact of doing exercise, of physical activity, will decrease the stimulation of inflammation that are at the base of the cascade that will start those inflammation diseases. of the intestine. So the question is, the patients with IBD do enough activity? So the answer is no. In a study that was done in the United Kingdom, only 1/3 declared doing exercise every day. And so it wasn't enough. It wasn't important enough, just a third. And another study closer to here in Canada by colleagues in Ontario, Dr. Macke and his colleagues, they have taken I did a questionnaire on their level of activity, and we see that only 58% of the subjects, 58 were inactive, and 53 for you see in 50% for healthy controls. And so that means the patients with the Crohn's disease were more inactive than the patients that were considered healthy. And we can see that the risk of inactivity is much higher when we have a Crohn's disease, especially when we compare subjects of the same age and the same geographic location. The question that can be asked then is to say, for what the factors associated with the lack of physical activity, one of the reasons that the helping the most is fatigue, chronic fatigue. Another reason are like joint pains, pains in the stomach and the muscles. Finally, motivation, that is a lack of motivation in adults, but also in children. And so we're asking the same question, especially for children that are followed in our center and CHU Sainte-Justine. What is their level of activity? Children that have an IBD. And so we create this study on a line where we ask them a question every 3 months to find out what are you doing as activity? What are your quality of life? What is the activity of the sickness, the disease? And this study has given interesting results. 261 children were included in the test, and these are an example of the questionnaires that are used in the big studies in Canada on physical activity in general populations. And as we see here on this questionnaire, the questions that can quantify the frequency, but also the level of activity considered as being intensity that is moderate or severe, that permit to define the level of effort. And so in the end, we realize that when we ask the question, did you do activity in the last 7 days? And we have 83% that say yes. If the activity made you sweat, 78% that say yes. But when we look at the level of activity, does it respond to the criterion in Canada? There's less than a third that do it. So 30% only will fill out the criterion of the directive that corresponded to at least 60 minutes of activity of moderate intensity. And so what's also interesting is that when we ask the question as to know, do you know the national recommendations, 40% will say yes, but there's only 12% that answer correctly to the question. And so that is an element that permits us to say that the information on the role and the impact of the activity must be vehicled even more now, especially in the context of the pandemic, where we saw a decrease of activity, whether it be in general population or in patients with IBD. And so there's a work of communication to be done there to encourage and to help, and especially everything that concerns fatigue and anemia. It's important for chronic fatigue. And then the factors, psychosocial factors of environment that were underlined as being associated to IBD. And so by the fact that there's a mechanism in place, that depression, stress will bring a production of inflammation, inhibitions of certain nerves that act on the microbiomes, increasing the permeability of the intestine. All these factors could be associated to an increase of the Crohn's or colitis. And so those were studies that were analyzed in many studies. One of the studies, for example, that was published in 2013, the study of the cohort of women, of nurses in the United States that were followed by over 20 years. So in this study, over 150,000 participants for over 20 years were questioned with questionnaires on their psychosocial factors that were asked to people in inclusion, but also in questionnaires during the follow-up. So they were able to identify 203 in this study. The participants that declared depression up to 4 years before the diagnostics have developed a Crohn's or Crohn's that was showing up in the follow-up. How to see it multiplied by 2 for those that develop or declare symptoms of a depression up to 4 years before the diagnosis. And so in this study, what is interesting, they went to see the presence of symptoms over 20 years before the development of the disease. And we noticed there also the existence of old symptoms that could show the Crohn's in the case of the follow-up. And so it's a study that had showed an association, but that was not the confirmed in other studies. This study that was done in Scandinavia. So the authors had used a criterion based on a factor of stress, major stress, the fact of losing a child, a concern as a high stress. So in this study, they took 21,000 parents that had lost a child, and they compared with 293,000 people that did not have IBD. 293,000 had not lost a child, and they looked at development of Crohn's or colitis. And in that study, we see that there is not an association between the fact of having lost a child and the presence of an IBD. And so effectively, the link between the factors, psychosocial factors, is still difficult to identify. One of the elements that will be important to study is the resilience. That is to say that the way that people who go through a stress situation will master it. And that is something that we're studying in the cohort that we have put together here in Quebec that aim to analyze the impact of these factors, psychosocial factors, taken into consideration the life of the patients on the way that they tolerate these factors of stress. And so the results will to come in the future. And then food, a big chapter, and the factors of risk, environmental risk. Food is increased intestinal permeability. It's a contact with the microbiome and a role, directive passage of certain antigens in the blood. And so all these elements could be part of the factors. And so many studies have been done to try to understand the role of food in the IBD patients. And even though all these studies that are multiple in nature, we have little data that is strong. And I did a resume of this on a table. When we look at the food elements individually, so as we take, for example, proteins, we showed in a study that the risk was increased for women in their 50s to develop Crohn's or colitis. But in other studies, this association was not found. Fatty foods were also shown in a study, but not in others. Conversely, with the fibers, and robustly are associated protection against the IBD Crohn's, but no link with colitis. And taking vitamin D or a lack of vitamin D is associated with an effect that's important of developing a Crohn's or a colitis. And so we will talk about that in the next slides. So globally, every factor, food factor taken individually, will give results that are positive in certain studies and negative in other studies, where the importance to look at the things under the angle of food profile, because it's important that when we eat to consider that we eat not just one food, we eat different types of profiles. And that's what was done in this work, where we looked at, it's a cohort, a European cohort that was put together over 20 years ago now. And in this cohort that is done in this country over 366,000 participants that answered questionnaires. And in the follow-up, we saw show up of Crohn's or colitis. And in this study, what was demonstrated as a factor increasing the risk of developing Crohn's colitis, sugar, carbonated drinks that are drank excessively, and not eating much vegetables. So this association was pretty strong, but was not found in other studies, notably this study that was published this year. So another study of a cohort, this time a bit large, 116,000 adults with an age a bit younger than the cohort. And these adults that were followed developed for certain IBDs 467 cases of IBD, and among them 90 had Crohn's and 377 colitis. And in this study, what was shown was that the fact of eating more ultra-processed foods has been associated with a higher risk of developing IBD, especially here with sugar, refined sugar products and drinks, carbonated drinks, and transformed foods. And so all these elements that are considered as being non-healthy food, transformed food, are associated with a high risk in IBD. But in this study, there wasn't a link between meat, whether it be the white, red, milk products, or vegetables, and the risk of IBDs. There was also another study that was recent that is still in the publication. It's a study that was done in the States. That was done in a cohort of 3 cohorts. In the first cohort, the women, the nurses that were included in this cohort, there was 2 waves. Wave 1 and 2. First was men that were also followed for many years, and on a total of 245,000, there's 481 colitis over time, and 369 CD was shown was that consumption of food that is very transformed is associated with the risk of developing an IBD, but not a colitis. So it's very important to develop a Crohn's disease when they considered notably that everything that was bread, everything that was transformed foods, sauces that were added to foods, cheese, all of that was associated to the risk, but no associations, contrary to the other study, with the sugar drinks or sodas. So we see here that the question of food is still an element that's very important. And in these studies, our challenge is to be able to characterize, as it's been shown in this work, the food profiles from data of questionnaires for certain people have been done a long time, for many years. So the strength of these prospective studies that the disease will be developed later, and we have less of biases by making mistakes and looking retrospectively. So globally, we see that there's an important impact for transformed foods on the IBDs. And then a factor in which there a lot of work that is being done, in which we are working as well, is vitamin D. And so vitamin D is an essential vitamin for the organism. It's a vitamin that's produced by 2 sources. The first source is the source of the sun, and so the exposition of the sun permits the body to produce vitamin D. And the second source is by food. And so the body needs vitamin D for many different functions, and notably immunological. We know that certain lack of vitamin D in animal models will be associated with the development of colitis in mice. And so on these elements that we are working around vitamin D, and also on the fact that the north-south hemisphere inflammatory diseases, and those are north of the hemispheres. So that's something that we have looked at in a study that we have done in France, in a study that was done the basis of administrative data, we have taken cases of inflammatory diseases, and we've looked at the repartition of the geography of these cases. And as we see on this slide here, that most cases are found north of France, and so the risk of developing Crohn's disease is almost double for those that live in the north compared to those who live in the south. And that is something that was also reproduced in another study in the court, a court of women that we had a bit less than 100,000 women of the in France that were followed for over 20 years. And over that follow-up, we saw a development of 123 cases of IBD. And what we've seen in that study is the exposition to the sun was associated to a lower risk of developing IBDs. Inversely, in that study, the report between vitamin D was not associated to the risk of Crohn's or colitis. But we have to underline that in the study, the report was pretty weak compared to what we could expect normal needs. And so these studies were also reproduced in the study that was done in the States at the cohort of nurses that were followed for over 30 years. This study having over 72,000 women from 40 to 73 years old. And in this study, they looked at the levels of vitamin D in the cohort and algorithm, and they looked at the levels of vitamin D. And from there, they were able to demonstrate that the risk of developing Crohn's IBDs were higher for those that had lower levels. So there are cohorts that are studies that concord so to say that there's a link between the lack of vitamin D and an IBD. So the question then that can be asked, did this lack influence the evolution of the disease? And that's what has been responded to in this work in patients that had already Crohn's already established. So over 3,000 patients, an average age of 49 years old. And in this study, they looked at the impact of lack of vitamin D at a rate of 25 OH, that's the marker in the blood, less than 20 on the risk of surgery or the risk of hospitalization. And so what was important in this work, the fact of having a low rate of vitamin D is associated to an increase of operations and hospitalizations. And the patients that would normalize their rates had less risk of developing these complications than those in the rate that had stayed low. And so there's a benefit in correcting the rates even when they are lower. Another work that has been done as well in the same line, where we see that to correct the rates in this study, the authors give big doses of vitamin D, 50,000 units per week or every 12 weeks. Every 2 weeks for 12 weeks. And then from there, they were able to observe the patients according to their blood levels. Those were at less than 50 per liter. There was insufficient between 50 and 74. And the vitamin D that was normalized, so up 75. And so what was interested in this study is that the participants that had a lower rate of vitamin D needed more steroids, so more visits in the urgencies and admissions in the hospital, more surgery interventions. But for those that had vitamin D, had less usage of the health services. So there was an important impact of the normalization of the vitamin D. So all these studies are observations, only studies that don't permit us to exclude a bias that is often important is the randomized studies. And so for the randomized study, there are not enough that have been done. The very first is the one that was done in 2016 with the adults known for Crohn's or an IBD in remission that were receiving vitamin D in one group and the other group a placebo. And as we see on this slide, the vitamin D was pretty modest, 1,200 IUs per day. In this study, the authors looked at the coming of a lowering of 12 months relapse 12 months after, and we could see that we have a decrease by a half of relapse for those that had the vitamin D group. And so we asked the question in pediatrics, in children that have a Crohn's disease, we could improve the situation by giving them vitamin D in high doses. To answer that question, we proceeded by steps. The first step was to establish the tolerance of those high doses. That first study that was done aimed at seeing if we could give up to 3,000 or 4,000 units per day in children, and if there was no secondary effects. And what was confirmed is that we could correct the blood levels because these children had rates that were already high after this administration, and they didn't have any secondary effects. So on this study, we included 20 children, and they were distributed in these different groups, and we were able to demonstrate that the fact of receiving a great doses of vitamin D permitted to correct the rates as we see on this slide. So we have an increase of the level of blood and D of those who receive vitamin D, and those that received the standard doses, the rate was increased, but not statistically significantly. Afterwards, we did a second study to see this time after 12 months. Was there an impact on the blood levels and the observance in that second study? We've included children that were put into groups, and we give them vitamin D, and we had followed them prospectively with visits and questionnaires every 3 months, and we looked also at the evolution of the disease. And so on a total of 24 patients included, they have an average age of 15. They were able to see the observance of these treatments was correct, but what happened starting on after 9 months, we had a decrease of the observation. So the taking vitamin D could at that moment be a challenge long term. So it's important when we talk about supplements that what we do, like in this study, is to think about the question of observing as time goes. So the studies that we had followed after these two pilot studies, this time to evaluate the impact of supplementing as and on this study we took the same doses as the pilot projects, and so in the group of 4,000 to 3,000 units for 4 weeks, and then 2,000 units for 48 weeks. On the inverse, we compared the standard group that had 600 units. And so the criterion to judge this study was really the following on different elements that we will see in the next slide. So the children had between 4 and 17 years old, inclusion of sickness that was in remission, and they received their treatments that are usual for the IBDs. Certain receive immunomodulators, other biologics, and vitamin D in that study was the next step for those usual treatment. They put in remission as well with little inflammation. We were looking at a marker that fecal calprotein dosage, and the criterion there to judge, we're looking at the symptoms of relapse, and we look also the increase fecal the calprotectin that should be increased, and also and those criteria that be a change of treatments that would permit that demonstrate that is the disease that is active, and that permits at that point to talk about a relapse. So we're looking now in this study the quality of life in the physical activities, and also hospitalization and number of hospitalizations. So to date, we've had 39 participants. It's a multi-centric study, 7 centers in Canada. So we're aiming an objective of 316 patients. And with the pandemic, we had many difficulties to recruit because there was a slowing down of recruiting during the pandemic. But the objective is to arrive there to be able to answer the question, is administering high doses will have an impact on the disease, and give counsel for supplementation on a larger scale. And finally, what we have as other work, which is really important, is this study that aims at analyzing all the factors that we've seen before, but taking into consideration the momentum of when these factors happen. So it's a study that we have a co-researcher here, Alma Frappier, Dr. Rousseau, and we aim with this study to more characterize the impact of these different factors on the coming of IBD or Crohn's colitis. So we have an interesting cohort of participants, 400,000 participants. They're born between 1970 and between 1974. And these participants, we've had identified 2,545 in of MC and 1,100, of UC. And my medical administrative data that was given to the participants this summer, in the summer of 21, and we've completed the questionnaire, and we'll be able to analyze the factors taken into consideration, for example, for the psycho resilience, not only of the living through stress, but how the stress was generated. The data and the results of this study will be very interesting, will permit to understand also how all these factors interact. Now, the puzzle is not complete. There are still things that need that are not understood. We know that our factors that are clearly like tobacco factors, appendectomy, they're clearly associated with the IBD. Several factors such as antibiotic therapy. We know the food, the stress, things that we must define. Vitamin D, what is its exact role in the evolution of the disease. And the momentum is really the key. So the factors that we could prevent are in particular the baby milk, not smoking during, not giving too many it's something that's hard to study, but we know that our days that there's an approach that was put together in the last few years on certain forms of appendicitis to start on a treatment in antibiotics and not to do the appendicitis. But the appendicitis must be done, and for that factor, we can't modify it. The other factors that are modifiable are the food. We've seen that foods that are transformed, ultra transformed, will privilege good consumption of food. And so for children, we know that in the case of the treatment of inflammation, nutrition has a positive effect. But the other types of nutrition are actually being studied, and the role on the evolution of the disease are still to be demonstrated. And so I'll finish here, and I would be happy to take a few of your questions. But I wanted to thank all the collaborators here that accompanied us in all these studies and this work that we've done up to now, and also the organizations, the finance, and obviously Crohn Colitis Canada that sustain us in this study as well. And I would be really happy to respond to your questions. Thank you very much. Thank you for this beautiful presentation with this information that are revolutionary concerning the IBDs, especially on the aspects that are concerning food, vitamin D, the IBDs. Thank you very much. And so we have many questions from our public for you, Dr. Jantchou. And because we have 30 minutes, we will go directly into that question period and respond. Thank you. Excellent. So the questions will show up on the screen in a few moments. So first question for you. What form of vitamin D is recommended for people with Crohn's disease or colitis? That's to say capsules, pills, liquid. What do we consider? So that's a very good question. Vitamin D has an absorption that is very easy, and the form to take is more dependent on the taste of the person in terms of ease of taking the capsules. We know in the pediatrics and children at a certain age, it's a bit more harder to make them under a certain age to take capsules, and liquid forms are more privileged. But with adults, whether it be capsule or a pill or liquid, absorption is pretty good for vitamin D, even in the context of these patients with IBD. What's interesting, and we've demonstrated in our studies, is that the doses are sometimes are necessary to get good blood levels, and that is something that's important. Where the importance of being able to do doses and to talk to the doctors to see if the blood levels are okay with what we're taking. For the function on the evolution of the disease, effectively, we have right now, we need certain data to be able to say what is the dosage that is ideal to prevent or help the evolution of the disease. Perfect. Thank you. So we'll go to the next question. So the next question, what are the secondary risks linked to the usage of vitamin D supplements? Those are things that are important to discuss in the context of vitamins that we can find everywhere. So one of the first risks, especially when we are taking strong doses, is the risk of overdose. Have very high levels in the blood, but that risk with the standard administration are less observed. And so we have an overdose of D. We get a hypocalcemia, which means that the rate of calcium in the blood increases. And if there's a high level of calcium in the blood, it could give stones. And so essentially that's the risk. But certain people will have high constipations, for example, etc. But the standard doses that we see are rarely associated to that level of risk. We have to signal that certain health conditions that are associated to the increase of the risk of having these calcemia. It's important to, when we have problems, health problems outside of IBD, to know that the rate of medication of vitamin D is different. Thank you very much. Great response. So the next question. So what is the quantity of exposition to the light that is necessary per day by day to have an adequate vitamin D exposure? So that is a question that has two questions. The first answer is at the moment of exposition during the day. So most of the time when we have exposition to the sun, it depends on the peak of the sun. So 15 minutes or at the peak when the sun is at its zenith, that produces enough vitamin D for the day. The second side of the question is the season, because the level of exposition and the way to absorb vitamin D depends a lot on the season in which we are exposed to the sun. For that reason, there are lacks that are higher in winter. For example, when we look at in our data, the patients that had a dosage in winter was very low because by the source of exposition is pretty low during the winter periods. And so the season is an important element, and the time of the day is important. But the 15 minutes at the zenith could be enough, and it's important to always talk about the risk of skin cancer when we talk about exposition to the sun, because it's something that we have to be careful with, don't neglect the skin cancer problems. So thank you for that response. And so for the next answer, is there exists other types of vitamin that aid in taking in control of the disease of Crohn colitis? That is a question that is often asked by patients. Should we take a mix of multivitamins? The answer often is not necessarily, only if there are problems in the intestines or problems due to food that is restrictive, but most of the time in a normal food consumption, even for those that have Crohn's that is severe, we don't need to take other vitamins. Often we'll dose the vitamin B12 for certain students that has important problems. But the other vitamins, there is not a specific use for them. Another question here. Many questions on the probiotics, but or the probiotics can be useful to reduce the risk of IBD. People who are not diagnosed, it can prevent those diseases. Knowing the role of microbiomes, there's a lot of work that has been done to try to see the benefits of probiotics and microbiomes in the IBDs. But right now, we don't have solid data to counsel and to say to use this and this probiotic. But what's important is the probiotics is a big family. On one side, certain species of bacteria that can be unique or multiple. In one probiotic, we could find 2, 3 different roots. And so very little data for probiotics. And inversely, the prebiotics which brought by the mechanics of probiotics that are richer and more varied. And so prebiotics, there's no data that is robust enough to consider that it should be administered systematically. There are a few works that have been done for Pouchets, the inflammations of the reservoir that are done for certain people in the colon, and that have this time the intestine that was used to make a new rectum. And those Pouchets, we could have benefits of certain kinds of probiotics, but globally the results are negative. And what's being studied right now is by transplantation rather than 1 or 2 or 10 kinds of bacteria, like in probiotics. It's rather a whole microbiome that we're transplanting. So the work in transplanting are in clinical trials right now, but it deserves a conference in itself. Perfect, thank you. And so for the next question, another question that was really showed up often about cannabis. So can cannabis, CBDs or THC, can it be used to reduce the risk of Crohn's and colitis or those different pushes? So that's an important question. As of today, the answer is no, because we've done recommendations about 2 years ago, the Canadian recommendations on the diseases of Crohn's colitis, but the data have not have no strength in the form of the strength or the benefits on this disease. So it's not something that we're considering for our patients for the prevention of relapse, for example. Thank you. Next question. Can the presence of chemicals in our water and agriculture soil be a risk factor to developing IBD? Yeah, those factors, environment factors, many have been studied. Everything that is pollution, in pollution, there's air pollutions, there's everything that's domestic, etc. And it's a study that's very interested, but hard to study because to be able to characterize the usage of water and composition and chemicals, and to follow, as we've seen in the studies of these cohorts for many years. It's works that is complex to put together, but those are ideas that have been brought up in certain studies, but we don't have solid data to say that such and such a parameter would be directly associated as we saw for food. It's really something that's interesting, but in which we cannot give a direct, a clear answer right now. And with this, how can herbicides and pesticides damage the microbiome? So I think that one of the mechanisms would be comparable to what we see, for example, on the food. Everything that is ingested will modulate the microbiome. And when we look at the composition of microbiome, according to the food, there's a change that happens very quickly. The taking of antibiotics is another model in which we could compare in the change of these microbiomes. So the factors of quantity is a factor that's important, and the factor of time as well. The duration of the exposition is important, and so what is demonstrated as we take, for example, the emulsifiers that are additives and all that, that are things that are also demonstrated on animal models. That work that has been done on animal models for emulsifiers would be associated to the important risk of developing a colitis. So I was speaking before of transformed foods, but there's also all that category of emulsifiers that are also present in food, for which it's difficult to quantify. What is the it's hard to transform food. We qualitatively try to estimate the type of food that we're eating, the drinks, sweet drinks, everything that's at pizza and other things. We can characterize them, or cooked foods. There were a study that was done in the States, foods that are already pre-prepared, foods that are transformed, and in that context that we could characterize them. But for herbicides and pesticides, the mechanism to go through that path, the length and the quantity of ingestion of these products. Thank you for the great response. So that was something that was wondering for a long time. So thank you for clarifying those points. So we'll go to the next question. So a question asked by a person in our community. I have fatigue and very low energy most days due to my IBD. Given the importance of physical activity in reducing the risk of IBD flares, do you have any recommendations for the low impact and or low intensity exercises? That is an important question, and as we've seen before, one of the parameters that limit the physical activity is fatigue, and fatigue can be caused to many parameters. The first time that when we see, for those that are, it's an important factor, fatigue, to make sure that the disease in remission, other parameters like anemia that play. Also, when we have anemia, there's less oxygen for the tissues, and then finally, everything that is activity profile of activities that are external to the IBD, and to give a counsel on intensity would rather be activities that are simple like walking, but to do on a regular basis that permit the re-education to strength, because the activities where we have a strong intensity and very spaced out, where they have less this action of re-education in the effort. But if we have all these elements and we can see that there's a tolerance, we can progress with our activities of moderate intensity, but the benefits are important on global health. Thank you. Next question on the list. Do you have any general advice for adopting a healthier lifestyle that includes physical activity and changes to diet? Yes, first idea is let go of the screens, and we see that a lot with teenagers sleeping enough, because sleep is an important factor, and we know that in the IBDs, often sleep is disturbed. And having this rupture between the screen and the moment of going to sleep gives it a better quality of sleep. And then everything that is food related, healthy food, will be encouraged, because we know that all the food will bring possibly diseases. The fact of having healthy food is a very important factor. And then finally, the other idea that we give, counsel that we give to our teenagers, because I see it's written to teenagers as well, is to do an activity that corresponds to their pleasure, because the activity will be more a pleasure than a challenge, and so it should correspond to what we like doing as a type of activity. And so to be able to identify what is the type of activity that we like better, and the group factor as well plays a lot. We know the stimulation between people is something that is encouraged. Walking, for example, is a good beginning. A gutsy walk, that's important. So that would be counsel advice that will apply to teenagers that are going to post-secondary school as well. Yes, the pressure of this school and studies are less sleep, be a lot more time with computer screens that are used for the school side. The students spend a lot of time on screens in school, but also for pleasure. And so the work that we've done, you talk about physical exercise, but we had a level of exposition to computer screens, being sedentary, many hours in front of the screen. And during the pandemic, we did another study where we included teenagers from Quebec in the general population. We had almost 1,000 teenagers that we followed every 3 months, and we analyzed their level of anxiety, depression, physical activity, etc. And we were able to see the fact of having little or having a lot of time in front of the computer screens is an important element that we should be able to control and decrease to keep a good repairing sleep. Absolutely. Thank you for those responses. So the next question. So given the relationship between diet and risk of IBD flares, how can someone in a rural or underserviced community get access to multidisciplinary care, including registered dietitians that are normally offered in urban areas or large healthcare centers? Yeah, that's a great question. What the pandemic has taught us is that with the possibility of doing different by video checkups is a nice opportunity to decrease the challenge aligned with these in the context of health and nutritionists that could also have a response through the possibility of having consultations by video, but it requires that there be time for the nutritionists to be able to take care of patients that are not in their centers. But the nutritionists that are trained, that work in the great metropolises, may have this possibility of seeing patients at a distance. For the group, there's a possibility of communicating well at a distance with the tools like we have right now, and to discuss with the patient on all the considerations of a diet. It's true that with the pandemic, it really changed the way that we communicate between people one to another, and so that opens new lines of sharing information in a virtual mode. Exactly. Thank you. And so the next question: do you have any advice for if your GI specialist does not knowledgeable about the role of diet in IBD and doesn't believe in the modification diet to prevent IBD flares? So that's a great question. To answer that, I will permit to share my screen. It would have been, if you permit me to share it. One moment. So this question is really important, and I think the gastroenterologists, those that do a study of inflammation in gastroenterology in general, like every doctor, we study on the evolution of what's being up to date, and this work was published in a scientific review, and that looks at the different types of diets. There are many different types. For those that weren't there at the conference at the June, we can send them to that conference. It was really great by the nutritionists that gave really in detail all the elements. I don't know Ariane how she was called, but we could trace them back and direct them to that conference. But it's really important, this work that I put on screen, that the researchers will look at closely the diets and the recommendations. How we can see here, the SPENS is a European organization, Bengen, BSG, British Society of Gastroenterology, IOIBD organization, IVBD. All those societies are pretty safe in these diets that for certain of them have demonstrated the effectiveness of those diets. That those are accepted by everyone for Crohn's and especially for children as a benefit and as the other types of restrictions, like the diets like FODMAP, CDED or SCD diet, or low-fat FODMAP. All these diets do not have recommendations that would be able to show the gastroenterologist. So to answer the questions also, because short answer, the proof is not enough to be able to say not take this or not take that, or not take excess of fat or meats, but especially to eat regularly and to eat with sufficient fiber, fruits, and vegetable. For example, well-controlled disease don't have to do restrictions of fibers, because of things that we can encourage people to introduce into their diet. I don't know if that corresponds to the answer you were expecting, but I think that's an important question. For now, the level of proof is not sufficient. There's a lot of studies, especially in 2019, 2020, works were done with the CD exclusion diet, but other types of diets were still waiting for robust data. So it's really a question of time before this information will be more developed. Yes, that's it. To see if we could get to find more than just a normal diet, it will be more effective. There's also the question not only of doing it, but with a nutritionist. What joins a question that was before access to nutritionists, and to observe these different diets, that there's a challenge that is there. And so it was really interesting. And so there were many other questions that came in. One of the first questions that I just received is, these factors of risk can be applied to the flare-ups, those that are already diagnosed. For example, the fact of not drinking sweet drinks, does it reduce the probability of those flare-ups? It's very important question. For the factors of risk, there are a few of them that have been confirmed also for those flare-ups, like tobacco with Crohn's disease, that will have a more severe disease and the risk of complication. But for diet, it's a bit difficult. A few studies have been done, notably randomizing the clients, because the best way to demonstrate the impact of a factor is to take two groups of patients. In one case, we do the change, and the other, we just tell them to eat normally. And one of the study that was done around the consumption of meat, and in this work, the study with the Crohn's colitis, there was no link between meat and the evolution of the disease. It's one of the factors that was associated to a higher risk of developing a Crohn's colitis. And there was not a link between the quantities of meat that were taken in the evolution of the disease. So for sweet drinks, I believe, without them being mistaken, there's no randomized study. We take patients and we looked at in one group versus another, the the evolution of the disease. And so it's much more, and by comparing the impact on the development of the disease, that we're asking to limit the intake, because we know the excess of sweet drinks will have an impact of the microbiome in the intestines. So yes, obviously that's really interesting. Imagine, once again, it corresponds to other questions that we need to have a robust data to be able to answer the question with more details. The other question that appeared many times tonight was, what do you consider a dose of vitamin D by group, age group, or even by weight, for example? Right now, we don't have a dosage to recommend it, because it depends on the health, the needs, and the recommendations. Between 600 800 units, that's like the normal needs. For certain people could be covered by the diet, but in other studies shown that certain patients, even with the food, does not cover their needs. But from 600 to 800 units per day to have supplemented intakes, we kind of generalize for those that are really important to discuss with the doctor according to the patient and the condition. And so these are data right now. The studies that we have seen, there are very few that have been done. An adult study, it was done here, and they went to doses of 50 units for 12 weeks. And so all these protocols are very variable, but there's not one level that we recommend for the adults or for children as a recommendation systematically. But it is a discussion that is accepted easily by doctors to know if patients can take and what doses individually. So I have time for one more question. Again, a link to vitamin D. It's to know if it's counseled to take vitamin D with other minerals or other foods or vitamins. To say to put it with other. Vitamin D, we could think that with fatties it would be more absorbed, but most of the time, what we know is better to take the challenge of these long or short treatments is not to do did I absorb it, but I will take it on long term. It's the key element. If we add a restriction of the type of food with which we take it, we risk of decreasing even more the observance of it. So to take every day during weeks and months and years, it's already an important challenge. Okay, thank you. And so that's all the time that we have for this presentation tonight. I want to thank the Dr. Jantchou. Thank you for being with us tonight, and thank you very much for having shared your expertise with us in our community on initiatives that are extremely important on inflammations, but IBDs. I would also like to thank everyone for joining us tonight for our series of learning, gutsy learning, and a huge thank you to BG Communications and Mike and Dave for their help tonight with the interpretation. They offer interpretation free simultaneously for our webinars. Thank you very much. A huge thank you to Sarah for having preparing this event as well. So a huge thank you. Final points I would like to share with you. When you disconnect from the webinar, a poll will show up, and it should take just a few seconds. We would really like you to have your feedback in your presentation of tonight, because these polls help us improve our webinars. The final point that I would want to share with you is that we are also on the social media. Our username is at Ayez du Crohn Canada or at Gutsy Canada. Get Gutsy at Canada, Facebook, Twitter, YouTube, and Instagram. Last point, if you want to give a donation tonight, you can text the word Espoir, ESPOIR at the 20222. It's Espoir 20222. Thank you again, everybody, for being here. Have a good evening, and see you next time. Thank you. Good night.